Hey guys, welcome back to Southern Union EMS's Toxicology Part 4 lecture. In this section, we're going to talk about specific treatment for cardiac medications and organophosphates. Within that, we're going to talk about the physiology of some of the actions of the drugs and then the effects of organophosphates on the body. And we're also going to talk about some of the antidotes as well. Your cardiac medications are very wide as far as the groupings of them. Um, Different types of medications have different functions. Your cardiac medications have dromotropic, chronotropic, inotropic effects, and the very same medications that we give in the patients may take at home for continued or maintenance control. The major classes of these drugs include antidysrhythmics, beta blockers, calcium channel blockers, cardiac glycosides, and angiotensin-converting enzyme inhibitors. You also have other classes as well, but these are the major ones that we're going to talk about right now. These medications are classified using the von Williams system. Medications that have similar mechanisms of action are grouped as Class 1, Class 2, Class 3, or Class 4. This is also previously discussed in Chapter 13, Principles of Pharmacology. Overdose of cardiac medications are usually unintentional. However, in several cases where I have worked, particularly involving cardiac medications, it has been the children, accidental ingestion of the children that's had major effects on. Typically, a extra pill for an adult won't have a lot of effects, but for children, this could have some serious effects or even death, especially small children and infants. Use a patient's history and list of medications to help identify the substances involved in the possible overdose. Very rarely do you see patients taking overdoses of cardiac medications to commit suicide, so oftentimes these are accidental. Your goal here is going to be to minimize the negative effects while determining the antidotes. As with all emergencies, you certainly want to ensure a patent airway, provide adequate ventilation, and administer high-flow supplemental oxygen. Also, be sure if you are unsure of the medication or the effects, contact poison control very early. You may receive an order to administer activated charcoal without sorbitol at a dose of 1 gram per kilogram if the patient is within the first hour of ingestion, or if the patient has taken an extended release type medication, activated charcoal may be considered as well. Do not administer activated charcoal if the patient is at risk for rapidly declining mental status, because the risks are going to certainly outweigh the benefits in this situation. So your sodium channel blockers, toxicity would include QRS prolongation, QT prolongation, hypotension secondary to depressed myocardial contractility, and ventricular dysrhythmias. Typical medications that fall under this class 1 are procainamides and lidocaine. Lidocaine is actually class 1B, and it particularly only works on the ventricular tissue. Beta-adrenergic blocker toxicity. So the effects of the beta blocker toxicity is going to depend on which adrenergic receptor is affected. Type 1, receptor beta 1 or beta 2 receptors. Beta 1 have the cardiac effects, whereas beta 2 have effects within the lungs and within the peripheral vascular system. Typically, though, beta blocker toxicity will present with hypotension, bradycardia. Also may see symptoms that are related to the decreased cardiac output, lethargy, weakness, shortness of breath, possible seizures. Hypoglycemia could be seen, especially in pediatric patients, and bronchospasm in patients with reactive airway disease. You may want to consider atropine for symptomatic bradycardia, but it may be useful only in mild doses. There is antidotes for beta blocker overdose. IV glucagon is a beta-adrenergic blocker antidote. You would administer 1 milligram of IV glucagon every 5 minutes. The patient may not respond until at least 6 milligrams have been given, so very rarely are you going to have this much glucagon on your ambulance. The ED may administer a glucagon infusion after the bolus has been initiated. Use normal saline or sterile water to reconstitute the glucagon, minimizing the risk of phenol toxicity. And be aware of the risk of increased vomiting from the glucagon administration. May have to consider vasopressor infusions such as norepinephrine or dopamine after you have provided adequate fluid resuscitation. Cardiac pacing may be required in severe overdose situations as well. And if the patient experiences seizure activity, then midazolam is the medication of choice to treat the convulsions. Potassium channel blockers, or class 3 antiarrhythmics. Amiodarone is in this particular class. So overdose on these may present with many bad effects: hypotension, bradycardia, ventricular dysrhythmias. One of the predominant effects observed on the ECG is the prolonged QT interval. The treatment of acute potassium channel blocker toxicity is primarily supportive unless you have torsades de Pointes, and then you would consider giving IV mag sulfate. Calcium channel blockers. Calcium channel blockers, this is going to include verapamil and cardizem. Due to the mechanism of action with calcium channel blockers, they may cause a decrease in pulse rate, decreased AV nodal conduction, decreased myocardial contractility, and severe vasodilation. Calcium channel blockers may also cause nausea and vomiting, alter mental status, and metabolic acidosis. IV calcium chloride or calcium gluconate is the initial treatment of calcium channel blocker IV toxicity, and IV glucagon may improve both the pulse rate and the myocardial contractility. Standard crystalloid infusions of 20 milliliters per kilogram may assist with hypotension, and recommended vasopressors after fluid resuscitation include norepi and dopamine. Another group of cardiac medications include cardiac glycosides. These are particularly problematic to maintain within therapeutic range. Digioxin has a very wide or a very narrow therapeutic range, and it may be difficult for the patient to remain at a level where the medication is providing its therapeutic effect and not increasing to a toxic level. Acute digoxin toxicity presents with nausea, vomiting, GI distress, and even lethal hyperkalemia. The antidote for digoxin overdose is digoxin immune fab, also known as Digivine. This is usually not administered in the pre-hospital setting. Because of the sophistication of cardiac drugs and the likelihood that the patient may be taking multiple cardiac and other medications, it is prudent to make contact with med control to consult with a physician. So moving on to organophosphates. Organophosphates are a major component in many insecticides used in commercial agriculture and in the home. Many of the agricultural insecticides that you will buy at Lowe's or Home Depot contain organophosphates. Developed in the early 1900s by German scientists that were trying to reduce the dependence on the importation of food by creating new insecticides. However, they found out very quickly that the people exposed to these insecticides experienced serious adverse effects. So the world took notice of this, and the role of organophosphates as a chemical weapon quickly arose. Organophosphates fit into the classification of acetylcholinesterase inhibitors. This classification also includes acephate or orthene, diazinon or spectracide, both of those can be bought in Lowe's, malathion, carbamates, and certain nerve agents such as sarin gas. Common exposure causes suicide, typically ingestions, accidental agriculture exposure, and exposure in the manufacturing setting. So organophosphates exert their effects at junctions of the nerve cells of the autonomic nervous system. The conduction of an impulse from one nerve to another occurs through the release of acetylcholine at the synapse, and ACH works as a chemical messenger, crossing the synapse to depolarize the nerve on the other side of the junction. So organophosphates and carbamates are potent inhibitors of acetylcholinesterase, which serves to terminate synaptic transmissions. This termination creates an abundance of ACH in the central nervous system and the peripheral nervous system, which then the muscarinic and nicotinic receptors become overstimulated, and this is where you're going to see a predictable response, cholinergic effects. The acronym here to remember is DUMBLES: diarrhea, urination, meiosis, muscle weakness, bradycardia, bronchospasm, bronchorrhea, emesis, lacrimation, seizures, salivation, or sweating. In moderate to severe organophosphate poisoning, the following symptoms may also be present: fasciculations of the muscles, severe respiratory distress, seizures, and flaccid paralysis. It's very important that you identify the source of the organophosphate and make sure you yourself do not become exposed. Decontamination is going to be the first component of assessment and management. This is likely performed by a hazmat crew. It all depends on local protocol, but you do not need to put yourself in this situation. Airway, airway, airway. Get the patient out of there. Maintain clear airway and administer high-flow oxygen and maintain SAT levels of greater than 94%. IV access without delay. And you want to administer 1 milligram of atropine, IV or IO, or by auto-injector, and repeat the dose every 3 to 5 minutes until easing of ventilation and reduction of secretions occurs. So the drug of choice initially in organophosphate poisoning is going to be atropine. Then you can consider up to 3 pralidoxime or 2 PAM injectors at 600 milligrams each in the first hour. Multiple doses may be required for patients with severe exposure. Want to continually monitor the ECG, pulse ox, and capnometer. And notify the receiving hospital early and transport to the appropriate facility. Again, atropine is a primary antidote for acetylcholinesterase inhibitor poisoning. Liberally administer repeat doses to symptomatic patients. Relief of bronchospasm and lessening of bronchorrhea indicate clinical improvement. Don't rely on the patient's pupillary response or heart rate to determine the clinical endpoint of atropine administration. Again, we're not giving atropine for increases in heart rate in this situation. We're giving atropine to actually provide an antidote to the organophosphate. We want atropinization to occur. And again, immediately transport. So this concludes the cardiac medication and the organophosphate lecture. Thank you for listening. My email is nickray@suscc.edu.